Hi, I'm currently studying 4th year MBBS student. I have my final year exams in 2.5 months, so I'm trying to complete my syllabus. I'm currently starting with medicine and that too cardiology. I'm making this video so that it would be a great source of teaching for me and I would retain the things. Okay, now I'm starting with cardiology, that too acute rheumatic fever. So everything in the university exams, we have to start with definition. We will start with definition, and after this we will write about etiology and then pathogenesis. If required, we will write pathogenesis, and then we will write about clinical features, investigations, management, and complication. Investigations, clinical features, investigations, management, and then we will write complications if asked. Okay, this is the pattern that we will follow for university exams. Okay, coming to the acute rheumatic fever. What is acute rheumatic fever? I will give a overview. If you ever have suffered with group A beta hemolytic streptococci, if your body has been infected with group A beta hemolytic streptococci, okay, group A beta hemolytic streptococcus, then what happens is that if suppose these are the two kinds of molecules, these are the streptococcal antigens, okay, the same kind of molecules are present upon the heart which mimics these molecules like streptococcal antigen. These two are mimicking this streptococcal antigen. So our immune, this is an immune. This immune has been attacked already on streptococcal antigen when we have been suffered with pharyngitis. Then these streptococcal antigens must be present in our blood. So our immune body has been attacked. Our immune body must have been attacked these antigens, right? So what happens is that the same molecules are present upon the heart too. Okay, our immune system suppose like this as foreign body, and then it starts attacking our own heart cells, thus resulting in rheumatic heart disease. Okay, so this is called as molecular mimicry. Okay, our body or body molecules are mimicking something else like streptococcal antigen. This is called as molecular mimicry. This is our pathogenesis. Okay, and coming to the clinical features, what are the clinical features? In acute rheumatic fever, we have 5 clinical features. Okay, we will be having one criteria called as Jones criteria, which I will be dealing later. And coming to the investigations, we will be dealing with the investigations and also the management. Okay, let's start. What is acute rheumatic fever? It is an acute multi-system disease resulting from an autoimmune reaction to infection with group A streptococcus, group A beta hemolytic streptococcus, for example, pharyngitis. Okay, an acute multi-system disease resulting from an autoimmune reaction to infection with group A streptococcus. And rheumatic heart disease. What is rheumatic heart disease? That is occurring because of acute rheumatic fever. This is nothing but permanent heart valve damage resulting from more than one attack of acute rheumatic fever. In 60% of the people who have been suffered with acute rheumatic fever, there are chances that you will be developing rheumatic heart disease. Okay, more than one attacks. If you have been suffered with one or more than one attack of acute rheumatic fever, then there is 60% chance that you might be landing up with rheumatic heart disease. Okay, this rheumatic heart disease is the most common cause of heart disease in children in developing countries. And coming to the acute rheumatic fever, it is seen in 5 to 14 years of school going children, and there is no clear gender association. Coming to the rheumatic heart disease, it is seen in 25 to 40 years of people and aged people, and females are more prone when compared to the males. And coming to the etiology, as I have said, upper respiratory tract infection with group A beta hemolytic streptococci. Okay, and I have already said you about the pathogenesis, that is molecular mimicry. This is the word that you must write. You should definitely write this word, molecular mimicry. Okay, and then immune response targeted streptococcal antigen. What are those? M protein, N-acetylglycosamine, carbohydrate. Okay, coming to the most favorite and most important part, clinical features. The clinical features over here are nothing but, see, first is what? Preceding subclinical group A streptococcal infection. Okay, you have already been attacked with group A streptococcal infection, and there is a latent period of approximately 3 weeks. Okay, this is the 3. There is latent period of approximately 3 weeks. Then later we will be developing all these things. First thing is migratory polyarthritis. Arthritis means inflammation. There is asymmetric inflammation of the large joint with tenderness. Okay, or it is getting migrated. Okay, it is not that it is staying in one joint. It is getting migrated. So it is called as migratory polyarthritis, such as knee, ankle, hip and elbow, and it's the most common presentation, and there will be complete resolution. There will be no residual damage occurring into your body. Then coming to the carditis, it's the most common thing. Most commonly we can see endocarditis. Okay, we can see most commonly endocarditis, and the most common site involved is valves. Our heart valves are getting damaged in this rheumatic heart disease, and this is the hallmark. Okay, and coming to the characteristic manifestation, mitral regurgitation, aortic regurgitation and mitral stenosis. These are the things you can see. And mitral valvulitis. This mitral valvulitis is nothing but, you can see fish mouth valves. Okay, if you want to remember this, you can remember. If you don't want to remember, you just write mitral valvulitis, that's enough. And then coming to the myocarditis. Okay, myocarditis is nothing but soft S1. Okay, S1 is being soft. And then first degree AV block, atrioventricular block, and there is prolonging the PR interval. If you even write myocarditis, it's more than enough. And then pericarditis, there is pericardial pain. Okay, there is precordial tenderness and pericardial friction rub. Even if you write pericarditis, it is more than enough. And then the third one, we are done with two. One is migratory polyarthritis, and the second thing is carditis. Now third one is Sydenham's chorea. What is the Sydenham's chorea? It's a characteristic darting movements of the tongue, spasmodic involuntary jerky movements. Okay, there's a jerky movements, involuntary jerky movements, that is called as chorea. Okay, it has prolonged the latent period. Okay, and females are more prone when compared to the males. We can also see milkmaid's grip, bag of worms appearance, jack in the box sign and pronator sign, and this is resolved within 6 weeks. If you remember all these things, it's good. If you don't even remember, you can write what is this chorea, and it has prolonged latent period, and the most common site is head and upper limbs are more affected in this thing. Okay, if you write this, it's more than enough. Coming to the erythema marginatum, these are the pink macules with central pallor and serpiginous edge. Okay, the site is trunk. Trunk is on trunk we can see more erythema when compared to the limbs. And the last clinical feature is subcutaneous nodule. These are the subcutaneous nodules are nothing but small, painless, mobile lumps that are formed beneath the skin. Okay, overlying bony prominences, that too on bony prominences we can see some subcutaneous nodules which are small and painless. These are the like lumps. Okay, these are like lumps we can see over hands, feet, elbow, occiput. Okay, and it also has delayed manifestation. Coming to the investigations, we have to check WBC count, we have to see ESR, and then CRP, C-reactive protein, ECG, echocardiograph, throat swab, that is we have to take throat swab culture, anti-streptococcal serology, ASO titer and anti-DNase B titer. These are the investigation you have to go for. And coming to the modified Jones criteria, the essential criteria, there should be evidence of preceding group A streptococcal infection. See, if you have already been group A streptococcal suffered with this infection, you will be having rheumatic heart disease, or else there is no point of getting rheumatic heart disease to you. I mean, in 60% of the people at least. Okay, so what's happening over here is this: there should be evidence of preceding group A streptococcal infection. How can we get this evidence? That is, if you take ASO titer in that person, there will be more than or equal to 250 units. ASO titer will be more than or equal to 250 units, and anti-DNase B titer will be raised, and then there will be throat swab culture is positive. Okay. How there's modified Jones, as if I have said, there's a Jones criteria. If I will be saying major criteria and minor criteria. If a person has 2 major or 1 major plus 2 minor, then we can suppose him as acute rheumatic fever. In initial acute rheumatic fever, in recurrent acute rheumatic fever, 2 major or 1 major plus 2 minor or 3 minor criteria. Okay. Coming to the major criteria, the 5 clinical features that we have already learned, that is carditis, arthritis, chorea, erythema marginatum and subcutaneous nodule. It is very simple. Coming to the arthritis, we have been divided into 2 things, low risk population and high risk population. In low risk population, if they are suffering with polyarthritis, that is low risk, and in high risk population we have polyarthritis, monoarthritis and polyarthralgia. Okay. And coming to the minor criteria, you have to focus upon this. Over this, first we are dealing with arthralgia. Okay, you have to find, you have to notice one thing. Over here I have said you arthritis, and over here I am telling you arthralgia. Okay, this is low risk population and high risk population. We have again dividing into low risk population and high risk population. Yes, over here you can see low risk population. Over low risk population I have written polyarthralgia, but in beside high risk population I have written monoarthralgia. Okay. And coming to the fever, low risk group, high risk group. Over here also, in low risk group there is more temperature when compared to the high risk group. In low risk group, if it is more than or equal to 38.5 degrees Celsius, but in high risk population it is more than or equal to only 38 degrees Celsius. And next is, we are done with arthralgia, fever, and then ESR, erythrocyte sedimentation rate, low risk and high risk. In low risk population, more than or equal to 60 mm per hour, and high risk population it is more than or equal to 30 mm per hour. Okay. And then C-reactive protein more than or equal to 3 mg per deciliter, and there is prolonged PR interval. So 1, 2, 3, 4, 5. There are 5 minor criteria and 5 major criteria which you have to remember. And the next point is the low risk population. The incidence is less than or equal to 2 per 1 lakh in school aged children. Okay, in school aged children. So coming to the management, coming to the treatment part, the drug of choice over here is the penicillin. Okay, penicillin, we are reading this acute rheumatic fever since our childhood. I mean, since at least from inter, we have been giving this penicillin, the drug of choice. Benzathine penicillin G, that is 1.2 million units. If you even write benzathine penicillin G, no need of writing the dose unless they have asked. Okay. And the alternative is phenoxymethyl penicillin or amoxicillin. And the aspirin, and then aspirin, this is for arthritis and arthralgia and fever. Okay, penicillin, aspirin. And the third is glucocorticoids. Glucocorticoids, for example, prednisolone. And for chorea, we are giving, if the chorea is mild, we are giving diazepam or haloperidol or diazepam. If it is severe, we are giving carbamazepine or valproate. Okay, if it is severe, we are giving carbamazepine and valproate. And the fifth management is bed rest. Okay, so what are the 5 in management also we are giving 5 things. So main major criteria we have read 5, we have in clinical features we have read 5, and also in the management we are reading 5, that is penicillin. And the second thing is aspirin for arthritis and arthralgia and fever. And the third thing is glucocorticoids. And for chorea, we are giving mild severe diazepam, haloperidol. In severe, carbamazepine or valproate. And the fifth thing is bed rest. Okay, there is 2 prevention in this: primary prevention and secondary prevention. Primary prevention is nothing but timely and complete treatment of group A streptococcal sore throat with antibiotics. You should completely treat group A streptococcal infection or sore throat with antibiotics. That is the primary prevention. Coming to the secondary prevention, it already has been occurred. So what we should do? Long-term penicillin prophylaxis. As a drug of choice is penicillin, we have to give long-term penicillin prophylaxis and benzathine penicillin G, 1.2 million units in every 3 weeks. Okay, and alternatively, if you are that is oral penicillin V and erythromycin for penicillin allergy. If you have penicillin allergy, then you can go for erythromycin. What's the duration then? Rheumatic fever without carditis, we are dividing into something: rheumatic fever without carditis, rheumatic fever with carditis but no residual valvular disease, and rheumatic fever with persistent valvular disease. Okay, if you have rheumatic fever without carditis, you should go for this treatment for 5 years from after last attack or till 21 years of age. If you are having rheumatic fever with carditis but there is no residual valvular disease, then you should go for 10 years after last attack or up to 21 years of age. Whichever is longer, you should go for that. Okay, rheumatic fever with persistent valvular disease, okay, for 10 years or till 40 years of age, or sometimes for lifelong. Okay, so now we are done with this acute rheumatic fever. So I have started this syllabus on 4 o'clock, and this is the first time that I'm reading. I want to complete my syllabus along with you guys. So it's been a challenge also for me. I am trying to complete this syllabus. Today I want to complete entire cardiology. Let's see whether I can complete or not. Okay, thank you. Please like, share and subscribe.